Good day to everybody listening. My name's Martin Kiernan, and it's my pleasure to welcome you to today's Weber Training Teleclass. It's my great pleasure to introduce our speaker, Dr. Prameet Sheth, who's the Chief of the Division of Microbiology at Kingston Health Sciences Centre, Associate Professor at Queen's University in Kingston, Ontario, and the J.N. Kendall Patry Clinical Chair in Genomics. Dr. Sheth is also the founder of Monarch Informatics, who specialize in data analytics and monitoring systems for healthcare. Those of us that work in infection prevention, microbiology, and healthcare, we're surrounded by data, but we rarely actually collect too much of it. And we do even less of turning that into information and insight. So we may have good information and quality indicators and turnaround times, but often we view those in a retrospectoscope rather than going forward or even current. So long after opportunities for prevention have passed. Today we're going to be looking at a different approach, and Dr. Sheth's going to talk about how real-time monitoring and evaluation systems can transform data into something we can use in an actionable manner. So I'm very much looking forward to this session. Over to you, Dr. Sheth.
Thank you so much, Martin. It's an absolute pleasure to be here, and thank you for everyone for being here, as well as, of course, Weber Training for allowing me this opportunity. This is very, very exciting for me. So as the introduction goes, my name is Prameet Sheth. I'm a clinical microbiologist at Kingston Health Sciences. And one of the things when I started practicing, and I started practicing about 12 years ago, so I'm going to date myself here, was the appreciation of just how much data we had. And then the realization of how poorly we actually used it. So hopefully you get to see kind of the inception of the idea, how we changed our processes, and then where we are today in terms of monitoring, evaluating, pivoting, and responding. I do have a few disclosures. So I did found something called Monarch Informatics, which is a data analytics company that specializes in data monitoring and evaluation. I am supported by the University of Kingston Hospital Foundation via clinical chair in genomics. I am an active researcher, and I have the privilege of starting, continuing, and doing research. And so I am the recipient of several research grants, including from the Canadian Institute of Health Research, NSERC, the Gates Foundation, the NIH, as well as more local grants like CMO and the Weston Foundation. Monarch was recently awarded something that we called the Helix funding, which was to startup companies to mobilize them and develop them as part of the Kingston Economic Development Fund. So a lot of this is a consequence of just a lot of support to myself personally, but also to the environment. And again, I like putting this right up front. Most people put it at the back, but I think the front is appropriate. Yes, I am on that slide, but I actually play a very, very small proportion of this. One of the things I realized when I saw the huge amounts of data that we create in the laboratory, but also in public health, was that I was not smart enough to actually understand that data, and nor did I have the ability to grasp just how large that was. And so I did something that I'm very, very proud of, and I asked for help. And I asked for help from the Center for Advanced Computing. Of course, today we know that AI is very much at the forefront, but this happened several years ago, and it was this realization that no, we don't know how to look at data. And I think that humility goes a long way. The other person on that slide, Dr. Henry Wong, who's on the left, is a data scientist and a assay development scientist. So he creates genomic assays. And then Calvin Sharda, who's in the middle between Henry and myself, is a bioinformatician and a data scientist. Of course, Paige, Dr. Hung, and Dr. Amal Khalil are all data scientists. They are all in specialized computer science programs. So they actually have PhDs in data analytics, computing, machine learning, and AI. So I clearly found the right people. But I think it's really important that we break down these silos, especially when we're going outside of our environment. Okay, so the objectives for this is to review current methods of monitoring and evaluating data, outlining some of the requirements for the development of a real-time platform, examine the impact of this and the fact that it needs to be an autonomous monitoring system because no one has time, at least in infectious disease, but in really any setting, and then consider the future implications and how we can make data-driven decisions, whether it be in patient care or IPAC or clinical practice. So one of the first things when we look at the spectrum of what a monitoring and evaluation system should look like, and the first one is, are we able to actually put something into place? Do we actually have the basic data? And then the question is, what do you look at? So agreeing on outcomes to monitor and or evaluate, like what specific things are you looking at? This becomes less of a challenge today in the AI landscape because you can actually look at a lot more things. The problem becomes, are you as a user able to digest that level of data? I think the next component is selecting key indicators to monitor outcomes. Like, what do you consider acceptable and what do you consider unacceptable? And a lot of people will say, 0% is acceptable. In terms of bad outcomes. And you say correct, and that's ideal. But even in manufacturing, we have a little bit of play, hence the P of 0.05 was actually from manufacturing in terms of, the ANOVA tests and some of those that we've adopted in science. And so it needs to be grounded in reality as well as what you think is indicated. Baseline data is really, really important. Like, where are we today and where have we come from? And that really makes up the crux of your evaluation for whether you're ready. The next step is, once you know your baseline, are you happy with your baseline or do you want to change or alter your targets? And that is an important concept because a lot of people will say, okay, this is data, we're going to look at it every 4 months. Not really ideal. We should be looking at it much more closely. Even if the data doesn't change, that's kind of the point of a monitoring and evaluation system is maybe it doesn't change, but when it does change, you know about it. The continually monitoring of those results and then the evaluation of that monitoring. So if something does change, if that is the cause and what is the cause, what kind of effect does it have on you? And then how do you mitigate that effect if it's a negative effect? Of course, as a consequence of that, you have to report those findings somewhere. So you have to tell somebody, whether it's a supervisor or an organization or a client or a user, or even to your own department to say, look, this is what we found. This was what the evaluation found. And that serves two purposes. Number one, it allows for historic evaluation past or before the monitoring started. And then number two, it allows for a deep dive into the quality control aspect. Have those findings actually been reproduced? And should they be reproduced? I would argue, yes, they should, unless they become new baseline. And then, of course, the last part, which most people don't do, at least we never did in our organization, was sustained systems. We would always become busy. So I'm a microbiologist and I run the clinical microbiology lab here at KHSC. And we had a monitoring and evaluation system before this was created. And then COVID hit. And COVID took a major toll on us, as it did on most people. And we became too busy. We became too busy to monitor the day-to-day. Because we were constantly putting out fires. And that was actually what led to this development was, if we're too busy to do it when it actually matters, this is a major, major problem. Because when things start breaking down, they usually break down in pairs or groups. And actually, that's exactly what happened. Is we stopped monitoring because we didn't have personnel, we didn't have time, we didn't have the ability to do it. And all of our quality metrics actually slipped. And so now we're coming back, but of course we have this new tool. Oh, sorry. in clinical labs, this is really, really important and comes to the forefront, partly because depending on who you ask, anywhere between 60 and 70% of medical decisions today are made as a result of laboratory findings. And that's true for any situation, right? If you are positive for Ebola, Y will happen. If you are positive for influenza, X will happen. If you are negative for MRSA, Z will happen. And so these laboratory data actually lead to patient-centered care, but also epidemiological changes. So if there's an outbreak we had an outbreak of Listeria earlier in the year in Ontario here in Canada, and had we not had a reporting and monitoring evaluation system, we would not have known until it was too late. And to be honest, we actually did know when it was a little bit too late. So from a clinical lab perspective, because we generate so much data, and this can be attributed to other areas of healthcare, it doesn't have to be the clinical lab. I just go here because that's what I'm most akin to. But in the emergency department or in the ICU or at public health in terms of outbreaks or opiate use, it really doesn't have a threshold of which you have to achieve. It's just, you just have to monitor it over time. Okay. So one of the first questions we asked was, what is a quality indicator? Like, what does that look like? What are we trying to monitor? And so I went through and I said, okay, well, let's look at the ISO guidelines for laboratory quality indicators. And it states that the lab shall implement quality indicators to systematically monitor and evaluate the lab's contribution to patient care. Kind of random. I don't actually know what that means. Sure, you can systematically do anything, but what does that mean? There's no top, there's no bottom, there's no base. It just says you will do something. And that's great, but what will you do and how will you do it are two different questions. And so we think about time, and time is really important in medicine as it is anywhere else. But we think about time and we say, okay, well, time is a really good quality indicator because if something happens, you want to respond in a timely fashion. And so this was something that was made by some colleagues at the University of Toronto, and they're part of the Quality Council for Lab Medicine and Pathobiology. And they thought, okay, well, you can look at time as a quality indicator. How quickly do you turn something around, whether it's a test or a result or an intervention? And again, you can apply this to anything, right? You could talk about time to admission from eMERGE, or you can talk about time to delivery of something. And so then the question is, when do you start measuring? Do you start measuring from the time the patient presents? Or do you start measuring from the time you have access to that specimen or that intervention? And that's an open question, right? Like it could be both, either, neither. But what I'm trying to get at is every little metric is and does get broken down into these subparts. And one of the problems with things like turnaround time is some people will measure something that's a therapeutic turnaround time. Others will use analytic, and then a third group will use clinical. Of course, all of them are reported as turnaround time. And so when you put it out there, they go, well, your turnaround time's way worse than somebody else's. And you go, where are they starting to measure their turnaround time from? If you're looking at therapeutic while they're looking at analytic, that's apples and oranges that you're trying to compare. And so this concept of quality indicator becomes a really important aspect because that's what you're going to use to monitor. So this was our quality indicator sheet that we used forever. It was quite embarrassing. I remember seeing this the first time. And one of the things that it has is it has the selection of the indicators. So you can put in whatever you want. It's a simple Excel sheet with very ugly yellow shading. It designates the frequency of reporting. So right here is, it says quarterly. Oh, it goes to the next one. Sorry. It says quarterly. So that's 4 times a year. And then we say, well, how does this outline actually fit with the strategic priorities of our initiative or our organization? And then we fill these in with Excel. Now, whoever fills it in may fill it in wrong, but there's no cross check for that because there's no raw data being presented. It's just an Excel sheet with a bunch of numbers. You don't know where the numbers came from. There's a format for acceptable target, not meeting target, and then not acceptable target. And those are created. Sometimes there's literature, other times there's not. And so really it's a blank sheet of whatever you want. A lot of people say that you should be able to meet your targets. I would say if you constantly meet your targets, it's actually a very poor indicator. And part of that is because why monitor something that's not a problem? For it to eventually be a problem, sure, that can happen, but you would catch that hopefully with other processes that you have. So what you want is you want a quality indicator that maybe you're not meeting to actually aspire to meet and have that intervention. So this was our sheet. It's very bad, but it was what it was. And it was like this for about 15 years. And so, the problem though, with any sort of metric is you choose the metric, but that metric has to be grounded in something. It has to have some sort of impact on your environment. So if it's laboratory performance, if it's clinical outcomes, it needs to have something. Number 2, the data that we usually have sits around until we have our quarterly evaluation, and then we look at it. And I got this from Linode Samuel, who's used to be, and I think is still the division head for Clin Micro at the Henry Ford Center, and this is used with his permission. And then reviewing these metrics offers you almost no opportunity to respond in real time. It offers you historic possibility. And a lot of times problems come and go, right? We know this. You'll have a major upswing of things because you've got some sort of breakdown in some other process. And then that process changes or gets fixed or gets altered, and all of a sudden the problem's gone without you even knowing about it. The question is, should you even bother knowing about it? Yes, because it can and probably does have impact on care or outcome. And so I love this quote. I don't know if Albert Einstein said this, but I've got it in here. A lot of things are ascribed to Dr. Einstein that may not be him, but not everything that can be counted counts, and not everything that counts can be counted. Absolutely true. Not everything that can be counted counts. And so what is it that counts? And so we picked one of the easiest ones. And so we looked at blood culture contamination rates. So blood cultures are commonly used as a way to diagnose sepsis. They are important because a contaminant or a skin contaminant is not indicative of sepsis. It's indicative that you drew the blood culture incorrectly and you probably didn't clean either the bottle or the patient's site. And so we know that getting a blood culture contaminant can and does increase your time on therapy. It can and does alter hospital stays, so it causes you to stay in hospital longer. And it does have inappropriate use of things like antibiotics, which in the end leads to increase in resistance. So the American Society of Microbiology put together kind of an overview of blood culture contamination rate. And they said anything under 3% is recommended, and that we should aspire for at least under 3, and really we should target under 2. But they didn't tell us how to do it, and they didn't tell us how to measure it. Now, contaminants, we know the organisms that are associated with blood culture contaminations. So they're usually coag-neg staph, so not Staph aureus. They're organisms that are on your skin, so Corynebacterium, Micrococcus. Propionibacterium is another one. So Propacnes is now called Cutibacterium acnes. It's the organism that causes acne, but doesn't actually cause sepsis. And so you have this beautiful definition that actually has some baseline. And so we thought, okay, let's look at blood culture contamination. And so we picked a couple of metrics. And then we said, okay, we want to achieve anything under 3%. We then picked a couple of champions and said, you know what, you guys are the champions. You're going to monitor this for us historically. We're going to build a system prospectively to do this. And then we said, okay, now we know that this was a metric before. So we already had collected pre-intervention data. And then we said, let's monitor. Now, the laboratory was able to monitor this on a monthly, which is not ideal. And so we created this real-time monitoring system that was better. And then we said, okay, let's try this. Okay. So for me, the dream monitoring system is it's consistent. So it doesn't take holidays. Number 2, it's autonomous, meaning it doesn't need a person. Number 3, it's easy to use. So point, click, tabs, nothing too exciting. Number 4, it's customizable so that what I look at and what you look at are different because I may be interested in A and you may be interested in B. Number 5, it monitors things at the same time and it monitors multiple things seamlessly, which means I don't need to do anything with it. I'd like it to be real time or close. I want it to be interactive. So I don't want to constantly look if I have a problem. It should be telling me I have a problem. So it should interact with me in some manner to say, hey, buddy, I know you've got me in the back and I know I'm looking at your data. You need to look at this now because now you have a problem. You haven't had it for 6 months. And then at the beginning, I need to be able to set thresholds to say when it gets above this, call me. But if it gets below that, don't call me. Right? So I should be able to set those thresholds based on what I like and establish what kind of alert system. Is it email? Is it a text message? Is it something else? And then last but not least, I want something around modeling. I want to be able to say, with the slope of this line the way it is, I believe that I can predict 2, 3, 4, 6 weeks into the future. So short-term modeling. Long-term modeling would be great, but you would need lots and lots of historic data for that. And so I will be okay with short-term modeling. And if you think about short-term modeling, it actually does a lot, right? If you can predict what happens in a week, 2 weeks, or 3 weeks, you can do things like reduce staffing or up your staffing. You can do things like order reagents or get more things you need to allow for that. You can increase or decrease capacity. That's huge because you're then using data-based processes to actually allow you to respond in an accurate way. So this was my dream monitoring system. And the predictive modeling is one of these fancy things because, as we all know, nobody can predict the future. So that comes with a grain of salt. And I think everyone realizes that, but it's still one of those and it's a dream. So it doesn't have to happen right now, but it's something that I would like. Okay. So what we did was we said, okay, we need to collect the data. And data often looks very ugly and looks like this. And we said it needs to be simple because we wanted to roll it out anywhere. So we said, okay, it could be an Excel file, a CSV file. It could be any tabulated data or separated data. Nothing fancy. Okay. And we outlined which things we wanted to look at. So we wanted some line of sight for bacteremias on where the orders came from, how it was delivered. So we have a pneumatic tube system. We also have active portering. We also provide support to other hospitals. So we have drivers that come in and drop off blood cultures. So we want to know how it came. We also want to know how it was collected. And again, this is specific to blood cultures, but essentially these are just variables you're looking at, right? And so that was our pre-analytic. We also wanted to look at how long things took to get to us, because that would help with our turnaround time. We wanted demographics on patients. We wanted things like date of birth, biological sex, because we know that's a variable that both of which are very important. And then we wanted some results, and they were very basic. So, for bacteremias, you think about a gram stain as being high utility. You think about growth, no growth, and then you think about what the organism identification is later on. Okay. So now we said, okay, how are we going to make this flow? So number 1 and number 2 is very unique to us, but I would like to start off with number 3. Number 3 is those files that you saw. And that does not require a laboratory information system or a hospital information system. It just requires a bunch of Excel sheets and CSV files. So let's start there. And so what we did was we created a folder and we said, okay, all the files got to live here. Initially, we wrote computer scripts that would communicate with number 2 and bring the files to number 3. If your file is already in number 3, you don't need to bring it anywhere. But what the script does is it grabs that file and puts it into an analytic pipeline. Now, this is really important because that script can work every week, every day, every hour, every minute, every second, right? It's just a script. And it's basically a computer doing something. Think about what's happening with your video right now. Your computer is continually interacting with your router, which is then continually interacting with servers, which is continually interacting with the world. Computers do this seamlessly, very effectively, very well. Why can't our script do this? So right now, for our purposes, we had the script running every day. We would run it at 4 in the morning or 5 in the morning, depending on what we wanted it to run. And we would pull all the data. And then we would clean up the data. So the cleanup of the data is essentially making sure that the structure of the sheet is patent and there aren't any errors. Like somebody didn't enter in, I don't know, an A where there was supposed to be a number. So if there was a number 6 for turnaround time for 6 hours, somebody didn't put 6A because that would confuse computers. And so that data cleanup had to happen really, really quickly. And then off it went to the monitoring and evaluation platform. And then that data got fed back to people that needed it. So frontline workers, institutional floors, public health, as well as to the lab people if that's what they wanted. But this was our flow. And number 3 is the critical piece. We didn't want to integrate it with the HIS or the LIS because if they break, the entire pipeline breaks. So why not keep it simple? A lot of places may not have fancy LIS or HIS, but we can integrate if we wanted. We had the scripts. But I just want to impress upon the fact that 3 is kind of where all the info sits. Okay. And so we developed this thing that we called LOLA. And so it's Lab Organizational Laboratory Analytics, or Live Analytics. Sorry, I always get that wrong. And so we developed this for KHSC Microbiology. And so we had 3 things. So number 1, you actually register for this account and it's personal. So when I logged in, it says, welcome back, Prameet. Select a department you want to go to. We do some genomic sequencing and I'll show you some data on that. We do microbiology, which is basic bacteriology, diagnosis of urinary tract infections, as well as antimicrobial susceptibility. And then we do molecular micro. And right now, for the molecular component, we have all of our respiratory viruses. So really the gambit, like basic micro, PCR and molecular, and then advanced like sequencing. And so, cool. So you pick which one you want, and then you go in. And you go in, and so this is our blood culture dashboard. And so very quickly, you just see on your right all the age demographics. So it looks like over the last 7 days, we have had 514 samples. So this is just the last week. You can see that it's a fairly skewed distribution. So, you don't get a ton of blood cultures in people under 35 or even 39. And then it starts increasing. And that makes sense because people usually use our facilities as they get older, because our population in Kingston tends to be a little bit older. So you start seeing the populations around between greater than 50 start coming through. And you see that demographic very clearly displayed. Blue is for male, F is for female, U is for undeclared. So you can see that there is a fairly homogeneous population of males to females overall, except when you start getting to the extremes of age. So 90 to 99 is predominantly female, and 100 and 109 is predominantly female as well. Right. There is a difference in life expectancy in Canada between males and females. And so, sure, it's interesting to see. And then we have blood culture results from location. So area 1, 2, 3, 4, and 5, and I blanked these out on purpose because it is semi-confidential. And so area 1 has the most number of blood cultures collected, and you could see that's just over 320, 25. And you can see that the purple is growth and the green is no growth. And so that tells you what the epidemiology is on a very basic level. This is last 7 days. If you clicked on last 30, it would re-evaluate the entire process and show you 30 days of data. You can go up to a year. You can go to max. If you hit max, I think you get about close to 600,000 patients, 600,000 samples. So quite a massive data set. And you can do this analysis at every time. If you click on the M for male, it actually gets rid of all the males and just shows you number of females. Again, you have numbers, you can convert it to percentages, and all of this gets done seamlessly on this. So that's our utilization. And then we have these tabs that tell us about positivity. So what rates of positivity do you have in what population? All of the areas are different areas of the hospital. So something might be, an inpatient floor, something might be general medicine, others might be emerge, others might be a separate hospital. We have about 7 or 8 hospitals on here. And then we, of course, have contamination rates, and then something we call blood culture analytics. And this is our thresholding and evaluating. And so this is our utilization. So we collected over 30 days now about 2,171 samples. So numbers are larger. You can see that area 1 was again predominant. You could see that there is trending on up down and what those areas are. I've shown you some data from the emerge. Emerge tends to be one of our busier sites, and you could see that between week 5 of 2023 and week 9 of 2023, at week 9 there was a little bit of a dip in under collection of blood cultures, but over collection of blood cultures stayed the same. So you can monitor things that are associated with utilization and appropriate outcomes. Location is important, and that if you click on area 1, it actually brings it down and shows you all of the other areas that you can. The timeline is really important because it grounds you to where. And then, of course, the trending data. Over and under is really important for optimal care and optimizing blood culture. So we thought that was important. Again, if you click under or over, it'll get rid of that and reanalyze it. But overall, our collection is fairly optimized because most of them are in the blue. In terms of utilization, we then map out individual areas. And what we find is the different areas have very different rates of over, under, or appropriately utilized. You can, again, trend this over time and actually identify which areas have trouble or not. Now, we know that there is a problem if you under or over collect in terms of outcomes for blood culture positivity. And so we wanted to pick that as our second quality indicator and metric. Now, positive blood culture monitoring is really important. The American Society of Microbiology tells us that positivity rate should be between 7 and 10%. And here we have an overall positivity rate of 7.65. All of the different areas have their numbers, and then you look at your age, sex, demographic, and you go, okay, well, this is my age, sex, demographic over the last 30 days. My overall positivity rate is 7.65. So between 7 and 10%. Great. In the past, we would always report, our ideal is between 7 and 10. We are at 7.65. We are perfect. And so we think about what kind of numbers are those? Is that really the right data? And you go, yeah, it's based on 28,000 samples. This is going to be real. And when you go to a year, again, our numbers didn't shift. So we were really, really, really proud of this. And then what we did was, because we were collecting area-based data, we said, well, let's look at the differences in the areas. And so we looked at area 1, and the positivity rate was actually under 6%. And if you have something under 7, you have the potential to miss bacteremias. And then area 2s, 4, and 5 were actually over 10%. And that leads to diagnostic accuracy, and in some patients can lead to, too much blood being collected over time, leading to a requirement for things like transfusions. So our overall rate was great, 7.88. And we never before had the ability to dig deep, because again, there was so much data, and we looked at all the data as one. And now we thought, oh my God, so we need to tell area 1 to change. We need to tell area 2 to change, area 3 to change, area 4 to change, and area 5 to change. Nobody was actually collecting it appropriately. It was just that everyone was negating the other person's challenge or mistakes. And so when you look at overall median or mean, you got to just where you wanted. And so this was actually really cool. We contacted, area 1 and 2 and said, hey, can we have a chat? Again, this is the kind of analytics that we are incredibly proud of and want to do, because this is actually what makes difference. And this can be, again, it's a surrogate marker for pretty much anything, right? And so we thought, okay, well, this is really cool. What else can we look at? And so we looked at the epidemiology of bacteremia at our site. And we found that area 1, 2, 3, 4, and 5, because they were different parts of the hospital, were actually quite different in the epidemiology. So area 1 had a very high proportion of E. coli, whereas area 2 didn't. Area 2's E. coli proportions were actually quite small. And even when you change them to percentages, nothing changed really. We know that different areas will have different epidemiology. And we thought, okay, well, let's look at a surrogate marker. So we looked at multi-drug resistant Staph aureus. So we looked at methicillin resistant Staph aureus. Our antibiogram suggests that 25% of individuals that have a Staph aureus, that Staph aureus is going to be an MRSA. And we thought, wow, that's really high. Let's look at the data. And so we went back and looked at multiple years worth of data. And what we found was that MRSA rates, which are shown to you in the green, are actually non-existent in people under 19. At the 19-year mark, majority of isolates are actually MSSA or methicillin susceptible Staph aureus as opposed to MRSA. And then the MRSA proportions actually increase substantially for individuals between 30 and 50 and then go back down. And I remember speaking with my infectious disease colleagues, and I said, we treat everybody the same in terms of organism, but we know that antibiotic experience and exposure are different for different age groups. You don't expect kids to have a ton of MRSA because they're not antibiotic experienced yet in most cases. You do expect those rates to rise, but for some reason we see reduction in the elderly for whatever reason, and I don't know what that is. It could just be changes in outcomes associated with MRSA that are at such high rates in individuals under 69 that you get a significant amount of mortality in that environment. And then the people that kind of go past that cliff, so to speak, have lower rates in general. But we don't actually understand why. And so it allows you to do little analytic things like this that can actually tailor interventions in therapy. And that's true. And so we thought, well, maybe there's a potential for age-based antibiotic choices, which we don't really do right now from an antibiogram perspective. And could this happen with things like gram-negatives? I know that gram-negatives that cause things like urinary tract infections are a major, major burden in terms of antibiotic use. So just a thought. The other thing it allowed us to do was to actually monitor average turnaround times by location or by organism. And we chose to do it from the outer part. So from collection to receipt. So when it was collected from the patient to how long it took them to get it to us, whether they did this by porter or by car or by the tube system. And then how long it took us after we received it to provide the first initial result, which was a gram stain. How long did it get from gram stain to organism ID, and then organism ID to final, and the final will be susceptibilities. And we said, 48 hours was absolutely the maximum, partly because you need bacteria. Bacteria need time to grow for the most part for susceptibility testing. And we were very happy with under 24 hours in most cases, irrespective of where in the hospital we looked at. And then we stratified it by bacteria, and it was interesting because a lot of our gram negatives actually were quicker than our gram positives, which also sometimes makes sense, others not. But we still met that 48-hour threshold for pretty much everyone. And so it's the exact same thing for contamination. Area 1 had a really low level of contamination. Area 2 had a really high level. And so when you average the two, it came up to 2.5. And so we just kept reporting, hey, we have no problems with contamination, nor do we have problems with utilization. And that just wasn't true. And so just to dig deep into the data and the ability to do this in real time, this is available at all times of the day to everyone and anyone in our environment that can use it to monitor. And then we wanted to look at trending over time. Like, what does this look like over time? Are there times in the year when it's particularly high versus low? And what we found was it doesn't seem to be a time-based thing. So on the left is percentage, and for area 1, on the right is percentage for area 2. And it looks like it just kind of bounces around randomly. We were thinking there would be like a really high point in the summer or low point in the winter for all sorts of other reasons, but it seems like some areas have problems and other areas just don't. And we're now working with area 2 to better understand what their challenges are and trying to correct that. And then the third thing we wanted to do was thresholding. And so we put a green bar at the 3% mark. And then we said, okay, like send us an alert anytime it goes over 2 standard deviations of where your norm is, because that's a major problem. And you could see area 1 barely breaks the 3% mark ever. And this is close to a year of data, 8 months of data. And then area 2 pretty much never gets into the green area at all, or gets into it but doesn't stay into it, and has some major, major challenges. Now, if we were to set the alert at 3% for area 2, we would get an alert every single day, which just makes it noise. And so we said, okay, 2 standard deviations from your norm, which would keep your alert at about 13%. And you could see that we hit that alert twice within that period of time. Is that a good place to set it? That's the place we set it. Whether it's a good place or not is open to interpretation and discussion. But essentially, if we set it any lower, we would just hit that alert all the time because our background was so high. We wanted to control it to some degree. And so what we wanted to do was we created the system where people had to register so we knew who was looking at it. We wanted to have access to some basic information. So obviously this is a fake one, but John Doe, their manager, their number, and then what clinic they are, where they're located. And then we had different levels of exposure. So whether you were an expert level or a novice level, and that gave you different levels of data based on your ability to access that data and your allowance to access that data. And so we think we've got this incorporated to some degree. And now we're at this 8 and 9 stage where we're trying to report these findings and then use these findings for sustained change, which I think is a very unique place to be, because everything before that, we will hopefully never have to rebuild. We could change it, but we have that monitoring going on in the background and never having to worry about it. And so now we can focus on number 8 and 9. And because it's a sustained system within the organization, 10, we just leave it there. Now, if we want to change or add, we can. But that is a very, very narrow kind of intervention as opposed to doing the whole thing for other quality indicators. The other thing is, because we built this pipeline, if we wanted to add on quality indicators, it's a matter of just adjusting the sheet to pull that data or include that data, and all of a sudden it'll appear on our system. We've done this again for respiratory. So we measure a number of respiratory viruses, flu A, flu B, RSV, SARS-CoV-2, OC43, human metapneumovirus, parainfluenza, as well as human rhinovirus. And so again, I've kind of blacked out COVID and all the other ones and just shown you data on flu A and flu B. On the top right is flu A, and I pulled this data out a couple of days ago, but you could see that we had some flu A activity at the end of last year, and really after about the 3rd week of 2026 or the 4th week, our flu A levels started coming down in terms of numbers. And then we had a little bit of activity of flu B much, much later in the year, so week 13 of 2026. And then the bottom left-hand graph is just showing you flu B kind of increased because I got rid of flu A. So it just magnifies it, and you could see that the number of samples were, never over 10 in a day or in a week. So this allows you to get to that data. We had tested about 800 samples during this period. So in terms of positive samples, so quite cool. And then again, same idea, gives us biological age, gives us who is experiencing what at what age group. So the top right is looking at different epidemiology in different age groups based on the different viruses. So you could see we saw lots and lots of influenza as well as flu B in the elderly. We didn't see as much of it in younger populations, and we kind of broke it down into age group because we were curious about the contribution of things like schools and children. Having said that, most kids that don't get very sick do not show up to get tested, so you have to kind of take that with a grain of salt. And then, of course, allowing us to do turnaround times again in terms of pre-analytics, so collection to processing to reporting. So again, it's the exact same thing. And again, this was the different locations in the hospital, who was seeing what and when, and then how many positive tests. Was it one positive test? So were they infected with one virus, or were they infected with 2 viruses? And you could see in the bottom right graph that majority of people were actually infected with one virus. There was a small number of people that had co-infections, but that question of co-infections always comes up when you get clinical severity like we did for influenza with Cade Clay last year. And so we were curious, like, did we see co-infections and that's why the clinical severity and hospitalizations went up? Not so. And really the other thing is, the thresholding, again, same kind of idea. But one of the things we wanted to do was add in this compare button so that we could effortlessly compare last year's flu season with this year's flu season. So this year's flu season was 2025, 2026, seen in the green on the left. And then last year's was 2024, 2025 in the red. And you could see that last year started earlier and was quite significant. But this year's was quite muted. And apologize, this is not influenza, this is COVID. We also wanted to look at geospatial modeling. So we support a large number of hospitals within our environment. We wanted to see where most of the activity was. This allows you to zone in and zone out. It allows you to see where the scattering of cases are. And then if you click on one of those, it'll actually tell you what viruses are circulating in that environment. And again, all of this is collected off that really ugly looking Excel sheet and then displayed for you to use and play with. So I'm going to stop there because I hope to have a few minutes of discussion, but thank you again for all of your time. I hope you kind of enjoyed seeing what we've done in terms of monitoring and evaluation, and happy to take questions.
Prameet, thank you so much for that. I've always been a great fan of data, although when I was working clinically, I didn't really have access to as much as we now get because of the computerization of laboratory systems, etc. I'm very interested in the blood culture contamination because that was the bane of my life. In that certain areas had very high blood culture contamination rates, and I really struggled to get them to take notice of it, and in particular the accident department, because people will come in possibly septic, take a blood culture, and they never see the result. The patient's gone, and their contamination rate was high, and I was struggling to get them to think of a what's in it for me if I take a bit more time over this positive blood culture. So, have you managed to learn anything about the underlying causes of the different blood culture contamination rates in different areas? And I've got a supplementary after that, but
yeah, great question. And yes, there is something that we've seen in terms of who collects the blood culture. We do see a difference between nurse collect versus phlebotomist collect. Phlebotomists are very specialized individuals that collect blood culture, and that's pretty much all they do, and they do it really, really well. Nurses, on the other hand, do it really well, except they're doing 500 other things. And so we do see a little bit of a difference. We also see a difference if the blood culture is collected peripherally or from a line. And that's an important distinction. A couple of years ago, we saw a massive increase in blood cultures, and they were all environmental organisms all across Ontario. And so we think the temperatures had gone up so much that maybe those blood culture bottles had been sitting in a warehouse and had gathered things like spores, because all of them were like bacillus species. So then we went out and said, you got to clean the top of the blood culture tube really well and let it stay there for 20 seconds, because it looks like you're inoculating what's on top into the media at the bottom. So we definitely have multiple avenues of dealing with it for sure.
Yeah, I mean, that's interesting, isn't it? Because you're able to pick up on possibly a system-wide issue, whereas individual hospitals may not have gone, well, we seem to have an issue. But if it's a blanket problem, then it's not behavioural in a particular area. I mean, we would have an issue sometimes with blood culture contamination going up at certain times of the year when the junior medical staff change and they haven't quite got the technique. And okay, here we go again. I've been down this road before. But the issues for me was sometimes I got the impression they weren't actually that. I've got my blood culture, and if there's a pathogen in it, you'll pick it up. And if it's a contaminant, it doesn't really matter. And sometimes it's explaining to people why, what the actual impact is. And I remember people being quite shocked when they found out that actually people are going to be on therapy longer. They could possibly be on hospital longer. They're possibly even going to be a risk of a secondary Clostridium difficile infection, etc. So that's an issue. Can I ask you then, you produced a few metrics. Which one do you think has produced the greatest clinical impact so far?
Yeah, so the blood culture contam is really important. I think the utilization is the other one. And both of those have impacts on diagnostic sensitivity and accuracy. So the two that we really, really kind of go after are our contamination rates, as well as our utilization rates. We had lots and lots of underutilization in certain populations, so kids. And we worked really hard for that because, in terms of blood culture contaminations, you think about staph, coagulate staph as being a blood culture contaminant, but coagulate staph does and can cause bacteremias. So if you under-collect your blood cultures and you don't collect the appropriate numbers, then all of a sudden, you don't know how to ascribe it as a contaminant versus a primary pathogen. And so obviously that's going to be a little bit worrisome, especially in populations like neonates, where, neonates are a very, very unique group because they are very, very small and they don't have a fully functional immune system yet, which means that organisms that may be less pathogenic in other populations do and can pose real concerns in that population. And so I think the underutilization is a major component. We don't get a ton of overutilization, but we have had some cases where people have had to get like blood transfusions at the end of 2 weeks because so many cultures were collected, and you kind of go, that's just not right. So I think those two would be the two. The other one that's really made an impact is the epi of respiratory viruses, partly because then it tells us when flu season is over and when it's starting, as well as what our baseline rates for things like COVID are.
Yeah. Okay. Now, have you managed to link any of these laboratory metrics to patient outcomes, like cessation of antibiotic therapy that was unnecessary and therefore reduced antimicrobial use?
Yeah, so we're trying to do that. We're trying to bring in, and that involves pharmacy because pharmacy regulates who gets what. We're also trying to look at length of hospital stay because that's the other one. And we're focusing on the ICU just because ICUs are such critical places in terms of limited beds, right? And so
absolutely.
The impact on the ICU is huge. And so we're trying to figure out how to link that data of, optimized collection or contamination to days of ICU and to potential for discontinuation of antimicrobials.
Yeah, and it's also the most expensive place in the hospital to be as a patient as well,
exactly.
Isn't it? So if you can reduce ICU stay, okay. Last question, Ren. Do the infection prevention teams or infection preventionists have any part in this, or do they act on these data? My first thought was, actually, if you've got nurses who are contaminating blood cultures in certain departments, and possibly these nurses cannulate, that may say something about their technique when they're taking a blood culture. That may improve their technique when they're placing an intravenous device.
100%. And I think that's a fantastic question. We do work with our infection prevention and control teams very, very closely. Things like Staph aureus and MRSA, and they're all linked to hand hygiene, right? And so there's a lot in terms of how do you use that data in real time. We're trying right now to use a little bit of genomics to look at nosocomial transmission, because we have this weird thing where we, at least in Canada, we ascribe nosocomial acquisition if you've been in hospital for over 72 hours, but not if that was picked up at 71 hours. And I always question that. There's got to be a more elegant way to do it.
I'm not sure the bacteria understand that, really. So, yeah.
Yeah.
Yeah,
And
that's
so
an odd one.
nosocomial transmission obviously is a major concern for IPAC. So, yeah.
Yeah, I've seen people struggling to get a C. diff fecal specimen at 36 hours so that they don't get tipped into a hospital acquired. So yeah, that's a good one.
Yeah,
Okay, well, thank you so much.
it's a weird system that we've developed.
It is, yeah, and unfortunately, you get unintended consequences then, because if there's a metric that get measured on a certain time scale, then people try to push it into one area or another. So that's a problem. Anyway, thank you, Prameet. I've really enjoyed that session. I've always been a great fan of data, and for me, no data, no problem. So the more data you have, the more problems you have. So that's another aspect of it as well. Okay, I'll just move on then to show you the
Perfect.
next
Thank you.
teleclasses. The next teleclasses on the Weber Training 25-year anniversary year. Next one will be the role of the environment in the transmission of infection. How can we intervene? That's an IPAC, International Federation of Infection Control teleclass, and that's a good friend of mine, actually, Professor Elaine Cloutman Green from Great Ormond Street Children's Hospital here in the UK. That will be a very good one. Then we have Mycobacterium tuberculosis transmission in healthcare settings. Professor Michael Klumpus, another fantastic speaker from Harvard University. Long-term care preparedness for the next pandemic, part 2, getting ready. National and local infection prevention steps, what it takes for success, and what's our role in preventing infections across borders. So excellent sessions coming up in June and July. And just to finish the day, the session, just thank our teleclass education patron sponsors, without whom teleclass education would not be possible. And that's Diversity, Virox Technologies, and the International Federation of Infection Control. Only remains for me to thank you, Prameet, for an excellent session. Thoroughly enjoyed it. I think people will get a lot out of it. And to say goodbye to everybody and see you again on another Weber Tele.